Well, welcome. Good morning, good afternoon, good evening. Given that this is a global webinar, ladies and gentlemen, we were delighted to invite you to the third webinar from the Coalition of Centers in Global Child Health. I'm Zulfikar Bhutta. I'm the chair of the coalition. And it's my great pleasure to invite you to this particular learning session and to introduce our wonderful moderator for this session, who will in turn introduce the panelists. So the Coalition of Centers in Global Child Health, as some of you know, is a coalition of centers interested in global child health in its entirety and in its wide dimensions. And it includes more than 50 centers now across the world, with about an equal distribution between high income and low income settings. The coalition has been doing advocacy and also is a portal of communication and learning. We have a website that I would encourage everybody to look at, that also provides information. And in the current context has been leading these series of webinars on COVID-19 and its impact on the lives of children and families across the world. We had a webinar on multisystem inflammatory syndrome at a very early stage in the pandemic, and then one on childhood vaccinations about a month and a half ago in low and middle income countries. Today's topic, particularly on gender equality and its dimensions in relation to adolescent health, is an absolutely important one, and is not only of relevance to COVID-19, but also to global health in general. It gives me great pleasure to introduce our moderator for today's session, is Professor Gary Darmstadt from Stanford University. I've known and worked and learned from Gary for well over 2.5 decades now. He's a giant in the field with a very wide interest in the subject of global health. In his capacity as the Associate Dean at Stanford and also a lead in his own program efforts, he was the leading spirit behind a Lancet series on gender more recently. So Gary, over to you. You will moderate this session, and I may come back right at the very end to make some announcements about next steps. Thank you.
Zulfi, thank you very much for that very kind introduction, and welcome to you all joining us from around the world as we join you from around the world. We're really looking forward to this session with you and in talking about some of the most pressing issues of our day. We're in the midst, as is obvious, in a pandemic that is wreaking havoc on all of us in various ways. We're going to focus this morning, this evening, wherever you are, on the impacts on adolescents. And already adolescents are falling through the cracks of our systems. We're going to look at ways in which COVID is accentuating that within educational opportunities, accentuating that for health. And specific aspects of health, focusing a bit on sexual reproductive health and looking at particular opportunities for youth coming together and making a difference by working together. We're going to be focusing on the particular dimensions of its effects by gender. The effects are different for across the spectrum of gender. And we're looking at important intersections between health, gender, pandemics, poverty, geography, and then of course overlaying with this all, which we won't really be focusing on this morning, is climate change and of course racial equality, which is on all of our minds. And certainly I'm coming to you from Seattle and has very much been on our minds over these last months. So it's my pleasure to introduce our fantastic panel to you. Jessica, if we can go to the next slide, please. And I'll introduce our panelists in turn as they come up. One thing I will say as we're moving forward here is that we're going to take your questions via the chat box. I will be moderating those questions and directing them to the panelists. So if you could please be entering your questions into chat as we go along. If you would like to Twitter, and I hope you will, you can see the link to the Twitter handle there that Jessica has put up as the first in the chat box. So here's our guest panelists joining us literally from around the world, from 4 different continents. And I will first introduce Dr. Jonathan Klein, and then the other speakers in turn. So Dr. Jonathan Klein, well known to us all for his role at the AAP, has now moved on to the University of Illinois at Chicago. There he is Associate Vice Chancellor for Research at that university, has an endowed professorship, and is playing a very active role within the International Pediatric Association on the Executive Committee, and as the North American Vice President for the International Association for Adolescent Health as well. Jonathan is going to give us a tour de force look at the impacts of COVID on the health of adolescents, looking at risky and healthy behaviors for adolescent health in the context of COVID-19. John, thank you for joining us.
Thank you, Gary. Good morning, good evening, everybody. I think I'm supposed to share my screen here so that we have slides, and I shall do so. Let's go up to the top there. Let's start with the first one, and can you all see the slides?
Yes.
Good. So as Dr. Darmstadt said, I'm going to spend a couple of minutes sort of giving us an overview of the landscape of adolescent health and adolescent health behaviors during COVID. And I'm not going to spend a lot of time talking about COVID in adolescence. So if we have questions about that, we'll probably need to put them into the discussion session. But just as a very brief overview. Again, the biopsychosocial development of adolescence includes the biological changes of puberty, children becoming adults, the cognitive maturation, the development of formal operational thought in the mid-teen years, and then the maturation of higher executive function up through the early 20s, and the social changes of adolescence, going from a dependent state as a child to adult interdependence with others, but as an adult. We often think about adolescent health as involving both the healthy and risky behaviors that adolescents engage in. And we will look at those behaviors as they're tracked by World Health Organization's school health surveillance and by the CDC in the US with the Youth Risk Behavior Survey and others to try to answer the question of what's changed and how has it changed with the pandemic. From the teens' perspective, of course, the main things going on in young people's lives have to do with their family, with their school, and their friends. And the pandemic has created a fairly unique combination of circumstances involving both the public health crisis, the social isolation and school closures in many countries, and the economic recession as a result of the COVID pandemic, which is causing its own set of problems, which affects all of those issues for most of our young people. Let me start just with a very brief consideration of access to care and health system disruption. WHO recently surveyed 105 countries on the continuity of essential services, noting that only about 80% of countries have established an essential service package, but that 90% of all of the countries had reported disruptions, with these being worse in general in lower income versus higher income countries. And the disruptions include immunization programs, immunization in facilities, non-communicable diseases, both their diagnosis and their treatment, family planning and contraception, mental health treatment, pre and antenatal care, and cancer diagnosis and treatment. And you can see the percent of countries reporting that. Now, obviously, this varies tremendously at the local, on the ground level. And I think it's important to recognize that our data and surveillance systems are also significantly disrupted, both by school closure and by redeployment of public health staff to the pandemic response. So as we go through the individual behaviors, I would note that we don't have a lot of new data. And the reason we don't have a lot of data is because either our data systems lag in what they're able to report, or because they are significantly disrupted as part of the care system disruption by the pandemic. We have a little bit of data from CDC in adults that 41% of US adults have either delayed or avoided medical care. And this is much worse for routine care than for urgent or emergency care. And what one considers urgent as opposed to routine has some interesting implications, especially for mental health and reproductive health for young people. So I think the most obvious impact that we're seeing really has to do with the mental health picture. And the economic downturn is historically, any economic downturn is associated with more mental health problems for young people, usually due to a combination of factors, including adult unemployment, the adult's mental health status, and an increase in child maltreatment. And usually these outcomes are mediated by both individual and family vulnerability and individual and family coping and resiliency. I don't think any of us need to be reminded that COVID-19 has led to stressful life events, social isolation, loss of control, worries about health, grief, violence, internet addiction, all of which can influence the mental health of adolescents. And the clinical symptoms that we see with this include post-traumatic stress disorders, depression, anxiety disorders, and grief-related symptoms. In addition, adolescents who have psychiatric disorders risk and have experienced a disruption of their care. So prior disasters have shown us that families who are exposed to quarantine measures report post-traumatic stress syndrome in about a third of the children in those families. And the post-hurricane surveys of some of the large natural disasters in the US have also shown that post-disaster suicide ideation is worse for girls, for those in lower socioeconomic status, for those with pre-existing and post-effect depression, with higher stress, lower family support, and of course, prior suicidal ideation. The data we know so far from the COVID-19 pandemic is a combination of adult and adolescent data. Between 4.5% and 7% of adults in China reported PTSD symptoms early after the pandemic and the lockdown there. Worse with women and worse with people who had poor sleep quality. A college student survey in China showed that if you had a friend or relative or acquaintance infected, you were more likely to report anxiety symptoms. And another survey of Chinese adolescents showed that 43% were reporting depression symptoms, 37% anxiety, 31% both. And again, young women were at higher risk for these symptoms. There's a little bit of longitudinal data coming out of the mental health field from the Zurich Social Development Project in Switzerland. This is a community representative prospective cohort study. And so they had prior measures from about 1.5 years, 2 years ago of stress and anger and internalizing symptoms. And they looked at that post lockdown and post initial pandemic, finding that there were increased levels of stress and anger, but not internalizing symptoms. And the strongest predictors of these were pre-COVID emotional state, economic and psychosocial stressors during the pandemic, and again, they're pre-pandemic stressors, including bullying and victimization and stressful life events. They also reported that coping strategies that were helpful at reducing distress included keeping a daily routine, being physically active, and being able to reframe things in a more positive light. From a violence perspective, looking at mental health, women and girls are generally exposed to more gender-based violence. And UNFPA says in their report, although data are scarce, it can be assumed that adolescents, particularly adolescent girls, are a population at risk of enduring violence during the crisis. It's pretty well established that home confinement can trigger interfamilial violence because of stressful life events linked to distress in parents, their lesser availability, and more punitive attitudes that come out during those conditions. In both France and Brazil, there have been increases in reported cases of domestic violence. And we know from other evidence that children are at greater risk of abuse and neglect in homes with domestic violence. In the US and in the UK, hotlines for domestic violence prepared for an increase, and many raised the alarm that there would be an increase, but actually experienced the opposite. In some regions, the calls to these hotlines dropped by 50%. And whether this is because of a lack of safe opportunities to call, or whether it's actually a decrease in incidents is not known. We do know that in the US, the criminal statistic reporting has shown that violent crimes and assaults and robberies have decreased during the lockdowns across our country, but that commercial property burglaries and also murders and shootings have increased. Again, how much of this involves adolescents, less clear, but certainly young adults are both victims and perpetrators for many of these crimes. So let's shift from mental health to a closely related issue, which is food and eating. And again, here, food security is a major issue for many people in the world. And the UN World Food Programme warns that an additional 130 million people will face acute food insecurity this year due to the pandemic, in addition to the 135 million who were already in that acute starvation risk before COVID. Again, this is mainly due to country-level disruptions in food supply chains and food production, but also due to loss of income, as well as to retail food price inflation. And the hotspots identified by World Food include fragile and conflict-affected countries where distribution is tough even without the social distancing issues, countries affected by multiple crises, including environmental or pests. Apparently there's a locust plague underway in about 23 countries. Poor and vulnerable people are going to be at increased risk. And in contrast to the acute food insecurity, about 690 million people around the world have some chronic food insecurity where they report hunger and food insecurity on an intermittent basis pre-COVID, as well as countries with significant depreciation and commodity price collapse, again, where the income affects the people's ability to obtain food. We have no data on obesity during COVID, even though it is a risk factor for more severe disease. We have a little bit of data on eating behaviors during COVID. An Italian survey of adolescents and adults found that almost half of the respondents reported they changed their habits. 17% said their eating got better, 37% worse. Similarly, eating healthy foods, more than a third said they do it more, and the same less. Eating junk food, 26% admitted they do this more often. Those with higher BMI, lower age, and who lost jobs were more likely to report this, and 30% are eating less junk food. Weight training, exercise, and sleep hours also increased for many of the respondents. In a survey that was mostly with adults in Poland, overweight, obese, and older respondents more often gained weight during the pandemic, and people who were underweight more often lost weight. So this is really going in both directions in this way. Now, on the other extreme for adolescent eating behavior, those with eating disorders, anorexia nervosa and bulimia, both in the UK and in the US, hotlines and websites reported an 80% increase in volume and online chats over their last year's numbers. And almost 90% of the patients surveyed in the UK reported their symptoms were worse, and 30% said they were much worse. Again, related to decreased control, increased isolation, rumination about disordered eating, and less social support, as well as the disruption in routine, time with friends and family. The report for discharge from inpatient units, treatment suspension or increased waiting lists, and limited post-diagnostic support. And I would say in our own program here, we've seen waiting times go up from a few weeks to 2 or 3 months. And that's been a common report from other folks around the US as well. Now let's shift to reproductive rights and health. And here again, we have a UNFPA report on the impact of the pandemic on family planning, gender-based violence, female genital mutilation, and child marriage, calling attention to the disruptions in family planning because of clinic staff either not having time or lacking protective equipment, to facilities closing or limiting services and people being afraid to visit services. Supply chain disruptions are projected to result in stockouts of contraceptives in many low-income countries in the coming months, with a projected 47 million women unable to gain access to contraceptives, resulting in somewhere around 7 million unintended pregnancies. And this, of course, is modeled projections. Similarly, interventions to reduce child marriage, including empowering young women, keeping them in school, addressing cultural norms, if implemented according to UNFPA's plan, were projected to reduce child marriages by 60 million people over the decade. The reduction in income and gross domestic product and delays in these program implementation are estimated that this will result in almost 13 million additional child marriages in the coming years. Now, obviously, for all of these issues, intersectionality issues, owning one, not just one, but many of the risk factors results in people being much worse off. But except for the obesity and BMI eating behavior, we don't have a lot of data in those areas yet. The other thing about sexual and reproductive health, again, many sources will look at this in regard to relationships, sexual activity, and contraceptive use. Natural disasters and economic crises, again, both impact these issues. Quarantines and school closures put young people with their families. They interrupt the normal trajectory of increased independence and sexual and romantic partners. For most young people, this has resulted in less partnered sex, although almost a third of adolescents report that even during the peak of the pandemic, they were meeting close friends in person. There have definitely been changes in the services available. The electronic health record survey data in the US showed that HPV vaccinations are down substantially and at a much greater rate than other vaccines, although some vaccines programs are certainly recovering now with the end of lockdowns. And 11 of our states in the US used the pandemic as an excuse to further restrict access to abortion as a non-essential health care. In a survey that Guttmacher Institute has done but not published yet, 40% of young women reported that they were planning to have a baby later than they had originally been planning because of pandemic issues. But it's also presumed that we'll see young people making up for lost time, both from the psychological fatigue from the behavioral restrictions and potentially with an impact that their ability to slides frozen. I hope you're all still hearing me.
Sounds like you've got your slides. You're okay.
Reports. Can you hear me? Are we still up?
Yes, we're good. Yeah, we can hear you and we can see your slide.
Yeah, we can hear you and you can see your slide.
I seem to have a slide. I get back to the presentation. You can hear me.
Yes.
Because it looks like I've got a title slide up there for something else. Okay, sorry about that. I'm going to go back to full screen if it'll continue to work. So for STIs, multiple press reports report foregone treatment and redeployment of STI program contact tracing staff to COVID. You know, if you think about public health departments, this is where all the infectious disease tracking folks were. And the Community Health Centers Organization in the US reports some clusters of STD cases. In Ireland, the surveillance data showed that almost all of the sexually transmitted infection rates were decreased from the prior year. Although this may be a lack of access rather than a lack of conditions. And interestingly, in Montreal, their health department reported a dramatic increase in STIs since Quebec reopened. But if you look at the numbers there for April, May, and June, the numbers were way, way down. And they're talking about the rise from 442 to 739, all of which are below their prior year numbers. Again, I think, as with some of the other conditions, the health department involved are appropriately concerned about the draw on their staff and on their ability to provide services. It doesn't necessarily bear out with the total data, at least not yet, and it remains to be seen how that will affect us. So, and then just to finish up with a quick consideration of substance abuse and COVID. Some use the risks associated with COVID. Certainly, we know that for a fact in the case of tobacco. Social and psychological effects of the pandemic also can intensify drug use, both in terms of the emotional impact on individuals of the quarantine, but also triggering relapse and intensifying their consumption. And so we have some data on alcohol. In Poland, there was some reported increase in alcohol consumption, worse in months. In China, 20 to 25% of people who drank. In the US and the survey of people living with HIV during the pandemic, there was no change in alcohol or marijuana use, but an increased consumption for those who were other drug users. And people's confidence in their ability to stay sober and their attendance at meetings to do that both decreased. And then finally, tobacco, both traditional combustible tobacco and electronic cigarettes. During the pandemic peak in Italy, smokers reduced their smoking during the lockdown, and about 3.5% quit. In Poland, 45% of smokers increased their smoking during quarantine. In adults in China, 20% of smokers increased, 25% of ex-smokers relapsed, and 8.5% of people quit. In a survey in the US, both smokers and e-cigarette users, about 30% of users increased. 41 and 46% respectively were unchanged, and 28 and 25% decreased. The perceived risk that their smoking gave them relative to COVID was associated with less use, and almost 1 in 5 said they had stopped smoking to decrease their risk of COVID. And similarly, in a survey in the Netherlands, moderate and high stress levels were associated with both increased and decreased smoking. For e-cigarettes, we have data from the first quarter this year in the US from CDC's school surveys, that showed 19.5% of high school students and almost 5% of middle school students were past month e-cigarette users. Among the high school students who were users, 38% used 20 out of the 30 days and 22% all 30 days, so daily users. For middle school students, again, 9.4% of users were daily users, not surprising here. These numbers are lower than the prior year. This is pre-pandemic. Whether this is a response to the e-cigarette associated lung injury conditions that drop those rates, or whether this is partial data because of the shutdown and surveillance in March remains to be seen. The Action on Smoking and Health survey shows that 1 million people have quit smoking since COVID, and 41% of those who quit in recent months report that it was because of COVID. And the University College London survey in the UK reported that more people quit between January and June in 2020 than in any prior year since they've been doing surveillance. So just to end up then, in summary, we've had significant disruption in health services access and use. We've had many stakeholders concerned about the access to their services, but very limited modeling and even less data on COVID's impact on adolescents and young adults' health and behavior. We do have a significant mental health impact. We have a significant impact on sexual health and development. And we have a lot of issues emerging for sexual health, abuse, food and nutrition, and tobacco. Strategies to address the prevention and amelioration of these risks moving slowly and competing for resources with many other services. And I hope some of our later speakers will address some of these strategies in greater detail. And our surveillance and public health programs and integrated clinical systems to address adolescents' needs are stressed and will likely continue to be so throughout the pandemic and in the post-pandemic recovery. Thank you. I'm sorry about the slide problem, and I look forward to hearing the other speakers and the discussion.
Jonathan, thank you very much for that comprehensive overview of adolescent health in this time of COVID. You've highlighted some of the gender issues, some of the issues that vary depending upon the stage of the pandemic, certainly some of the contextual issues as well. So thank you. We're going to move right on, and what we'll be doing is hearing from all four of our speakers and then having our Q&A towards the end. And as a reminder, you can be entering as we go along your questions in the Q&A box, and I'll be monitoring that. So our next speaker, we're very pleased to have Dr. Russell Viner, who's the president of the Royal College of Pediatrics and Child Health in England. He is a professor of adolescent health at UCL in London, is currently the vice chair of the NHS Child and Young People's Transformation Board for England, which is the chief body responsible for strategic oversight of children's health in England. Certainly one of the leading voices for adolescent health. And Russell will be talking with us about the impact of the pandemic on education and equality. Russell, thank you.
Thank you, Gary. So just checking you can see my slides and hear me?
Yes.
Brilliant, brilliant. Well, thank you. So COVID-19 in many senses has been an intergenerational cash transfer. It has been a transfer of money from the young to the old. The impact of COVID-19 on children and young people has been a relatively small direct impact for most young people, but a huge indirect impact. And one of those impacts has been particularly on education and then clearly on equality. Very early on in the pandemic, I think perhaps if we think back to February and March 2020, or January and then early February, we started to hear reports of a pandemic coming out of China and then affecting other parts of East Asia. those of us not from East Asia. And we started to see reports of schools either being closed or staying closed. Schools in China itself did not reopen after the Chinese New Year holiday. We started to see the part of the response armamentarium of nations to the pandemic was to go into a lockdown, a word which in a sense didn't exist before COVID, and the term social distancing again was not one we were using before COVID, but essentially very strict social lockdowns in many countries, and in the great majority of countries those involved schools. I was interested in this from a very early time, partly because of the work we were doing with the Chief Medical Officer and the government here in the UK. As the pandemic started to spread outside of East Asia, and particularly into Italy, we started to see cases arising across Europe, in the UK, and the question of when schools might be closed, as well as when other parts of society might be closed, was suddenly the order of the day. With some colleagues, we undertook a very rapid, systematic review of what was known about schools and coronaviruses. So just to remind you, COVID-19 is caused by SARS-CoV-2, a cousin of the original SARS virus, and has some similarities to the MERS virus as well. So what do we know about school closures and epidemic coronaviruses, and potentially about endemic coronaviruses? This was the subject of our review. We found there were very, very few data available, unsurprisingly. There was some data from SARS, and we found that there's very little evidence that school closures made a difference back in 2003 in control of the SARS outbreaks. That, with retrospect, that may have been because of significant differences between SARS and COVID-19. But it also spoke to different issues about this virus compared to other pandemics for which we're used to closing schools. This review was published in preprint initially in late March, early April, and then proved quite controversial. We certainly got quite a lot of opposition for it, some significant criticism for it, and if I think back to that period, it was a time of great anxiety and fear and a lack of knowledge. Much of what we know about school closures and impacts on education from pandemics, of course, comes from influenza pandemics, which is humanity's major experience of pandemics. But even in the influenza data, there was some very suggestive data suggesting that school closures are an important form of pandemic control if the R value is relatively low, so not when the R value is very high. And pandemic influenza most commonly has an R value of between 1 and 2, as opposed to SARS-CoV-2, which I think the estimates at the time, and probably still, are that it's closer to 2 to 3 to 4 in many situations. And also, school closures make sense when children are clearly super spreaders of the virus. And neither of those was true of SARS-CoV-2, and we could see that back in March and back in April. Yet despite this, we saw dramatic school closures right across, initially, as I said, East Asia, then Europe, and then extending into all continents and across all countries. Not all countries closed schools, but the vast majority of them did. There was incredible lack of clarity around at the time. This is a cartoon from Australia. My colleague Susan Sawyer may recognize it. This shows various state leaders of the states in Australia, singing from very different songbooks, keeping schools open, closing them, keeping them partly open, totally shutting them down. A source of great confusion, not just in Australia, but really very much across Europe and elsewhere. But what did happen, and I think you all know this, is a huge amount of school closures across the globe. This is a map from September, so it's very current, from about 5 days ago from the World Bank. If we had have drawn this map back in probably end of May, we would have seen much of the world in red or purple, i.e. closed. World Bank estimates at the time were that the great majority of countries and nearly over 90% of school children were out of school due to school closures due to the pandemic. Unsurprisingly, the consequences of this could be very great. Going back to this slide for a moment, as you can see across the world, the great majority of countries are a darker red, a lighter pinky red, or purple, or potentially the mustardy color, which is all of which is schools are partially closed or fully closed. Across the whole of Europe, schools are largely open, but with some limitations. So in many places, schools are opened with social distancing in place. In some countries, only certain year groups are back at school. In other countries, there are limited opening hours or rotating hours. So there are differences in the way that schools are open. In Australia, which is coloured mustard, in some states, schools are entirely closed. In other states, schools are entirely open. And we see the same across the USA. It's much of South America and much of Africa are the areas of the world, and South Asia, the areas of the world where most school closures persist, which is in itself a real concern in terms of the enduring legacy of this pandemic, which for children and young people will not be about clinical illness or death in the great main, but will be about lost opportunities, about poorer health in general, lack of protective resources, and lack of education or lost opportunities in education. Now, apologies for highlighting some of my publications, but they're useful aid memoirs for me. I think there were a number of publications out there where people, academics started to look at this issue of the balance of risks for children and young people. This issue of the balance of risks around COVID-19 has essentially been my work for the last 6 months. And I imagine it's probably the work of many of you there, which is about how do we advocate for governments and states to prioritize children correctly without focusing only on the clinical risks of COVID and only on the risks to the middle-aged and elderly, but focus on the rights of children and young people and the balance of risks for children and young people. Of course, there are 3 balance of risks. There are the balance of risks for children and young people themselves, which are very clearly in favor of schools being open and of children and young people continuing to be in education. There's the balance of risks for the adults they live with, for parents and grandparents, potentially those who are vulnerable, and for school staff. So the balance of risks for those they come in contact with. And that's a separate balance of risks and is related to issues around transmission in schools and transmission to vulnerable adults. And then there's the balance of risk for broader society, the impact of schools on the population reproductive number, the R. And the best estimates that I've seen suggest that school opening and closing do have an impact on R. Of course they do. Anything that we do in society will have some impact on pandemic transmission, but it's a relatively low impact of the order of 0.1 or 0.2 in terms of our currency. So again, I believe that the balance of risks in the majority of societies is absolutely about keeping schools open because of the harms that come from school closures. What are those harms? And John detailed those in many senses. I won't go into those in great detail. Education loss and the loss of life chances. Again, that's very difficult to quantify. Right early in the pandemic, it looked like this might only be 1 or 2 months. But as we can see from the graph I showed you earlier, in some countries, school closures are now potentially up to 6 months in length. And in some countries, there are no plans to open schools before the end of this year And given in the Northern Hemisphere it's winter, it's unlikely that in many of those countries schools will be open early in 2021. We're potentially facing the loss of up to a year of education for large numbers of children. Given that for many children and young people in high-income countries, education on average is 12 to 14 years. For children and young people in low and middle income countries, average length of education is often very significantly less than that. So for children and young people in countries where average length of education is much shorter than that, potentially 5 to 8 years, loss of a year of schooling is a loss of an eighth or a fifth of their educational life chances, which is an unacceptable loss. And again, results from states, from nations, prioritizing the health and well-being of the middle-aged and elderly over the life chances of children and young people. In the UK, a report by the Royal Society suggested that lockdown would result in the loss of around 5 to 8% of educational and life chances for children and young people if schools reopened in September, which they have in this country. Of course, there may be further educational losses over the Northern Hemisphere winter if further states go back into lockdown. The Royal Society also suggested that states will be paying for this loss of life chances for the next 40 years. And a number of economists have pointed out, I think I mentioned this before, that in some senses this can be seen as an intergenerational cash transfer of money from the young to the older. Okay, one of the key things about school closures is the loss of health delivery, the health programs which are delivered through schools. Real concern to many of my colleagues who work in lower middle income countries, particularly school feeding programs, immunization programs, and for example, mass drug administration programs for worms, school-aged children, etc., etc. Again, the cost of this will haunt us for the next generation. Okay, inequality, and others will talk much more coherently than me about this. I was very struck by this commentary in Nature, not generally a journal that gets into issues around equality, but pointed out, but infectious disease outbreaks always affect women more than men because of the structures of our society, because they bear the brunt of care responsibility as schools close, as family members fall ill. They're at greater risk of a whole range of outcomes due to isolation, such as lack of access, domestic violence, etc. And because they have more, because they are more marginal economically often, they're more affected by economic instability. And we know that this is undoubtedly true of young women. Now, the International Growth Centre and the London School of Economics did an interesting study on the impact of the impact of the Ebola pandemic on the lives of young women. And they found that school closures and disruption during Ebola outbreaks in West Africa led to an increase in child marriages, very clearly, and a failure to return to school post-crisis. That it was particularly young women, more than young men, although both young women and young men suffered in terms of a failure to return to school. It was particularly young women, not just those who were involved in child marriages, which is potentially keeping them out of school forever, but also broader groups of young people. And it's very pertinent and sobering to see that the Malala Foundation suggests that we may have 20 million more secondary school age girls out of school after this pandemic than prior to it. And I think this is a relatively old, when I say old, it's 3 months old. In COVID times, of course, that's now ancient. A relatively old study now. And of course, as the crisis goes on, I think this number is almost undoubtedly an underestimate. I'm going to finish quickly because I think other colleagues will address this better than I. What do we need to do? I think across all nations, we need to think very carefully about actions as many nations, particularly in the Northern Hemisphere, start to look at a second wave, and think about that balance of priorities, the young compared to the middle-aged and old. Think about the future of our nations. I think we need to make arguments that closing schools should be done late or if at all in social distancing and lockdown interventions, because I think that's where the science takes us. We absolutely need to be monitoring and supporting attendance in schools of both young men and young women, but particularly of young women, and working harder to address financial barriers to girls attending schools. We need to recognize that there may well be gender parity issues about access to distance educations, particularly in low and middle income countries. Girls often have less access to the technology needed. And above all, we need to make sure that young people's voices, including young women's voices as much as young men's, are part of our solutions to this. I'll thank you and finish there.
Russell, thank you very much for this fantastic and actually rather sobering overview of the implications of COVID on educational opportunities for our adolescents and the massive potential indirect effects on their educational opportunities and their opportunities going forward. So thank you for that. Again, a reminder about our Q&A. We have some questions coming in. We'll deal with those at the end. Our panelists can provide some answers as we go along, so I would encourage you to be following along with the Q&A as well as we go along. We're now going to turn our attention to Sapna Desai, who's with the Population Council in New Delhi. She is going to talk with us about another aspect of adolescents' opportunities, and that is the opportunity presented by coming together outside of schools. Given that as Russell was going over, schools across the world initially were largely closed. Some are now opening up in various ways. We're looking for other opportunities to engage with our adolescents, and one of the ways is through group activities. Dr. Desai is with the Population Council and with the Evidence Consortium on Women's Groups. She has a career of addressing women's empowerment, sexual reproductive health and rights, and is leading reviews on the mechanism of group activities, women's groups, self-help groups. You may know them as, for example, as vehicles for reaching adolescents and for providing services and improving health as well as economic opportunities. So Sapna, I'll turn it over to you. Thank you.
Thanks so much, Gary, and thank you all for having me here this evening. So we've learned a lot from our first two speakers on the indisputable, kind of very vulnerable situation that adolescents will be in, not just now, but also will continue to be, and how they'll be affected by COVID. So as Gary suggested, I'm going to take a slightly different view and really hone in on one potential intervention amongst many to mitigate the effects of this pandemic moving forward. So my comments today are really based on three sources of learning from the Population Council and the Evidence Consortium, which is a global consortium, and I have the great opportunity to really reflect on the work of many of the colleagues of mine in the Pop Council working across offices around the world. So the first is a set of ongoing research studies. The Pop Council has these very unique cohorts already in place with adolescents in several settings, as you can see on this map, in Asia, Africa, and the Americas, which are cohorts of adolescents set up to also examine gender differences, so they're boys and girls. And our first response to the pandemic was to try to capitalize on the already existing relationships we had with adolescents in these settings and find out what was happening from a multi-sectoral lens on health, education, livelihoods, and general well-being amongst adolescents. So I'll present some information from there. The second is an analysis we did at the Evidence Consortium, really focusing on 3 countries initially, India, Uganda, and Nigeria, on how women's groups, which operate at a very large scale in many countries, like in India, it's a national program implemented by the government, for example. So you will see women's groups in almost every village. So we tried to examine the impact of COVID on groups to understand the challenges they were facing, but also how they could be reoriented in a sort of post-pandemic future. And that really draws me to the main source of information I'll be presenting to today's work. Colleagues of mine led Hannah Briggs and Nicole Haberland, where we worked together to look at the impact of COVID specifically on girls and the potential roles of girl groups, excuse me. So I'm going to present a very brief snapshot. There is a lot of data available, all of it's publicly available on our Dataverse site. But just to give you a snapshot of what we've been learning in 4 countries, in India, Kenya, Mexico, and Bangladesh. So we know that adolescents have lost social connections and support, schooling being the primary place of that support. So for example, in Mexico, in surveys in Chiapas and Yucatan, nearly 1/4 of adolescents discontinued their education, not surprisingly. But interestingly, I was higher amongst boys in Chiapas, whereas equal amongst girls and boys in Yucatan. So you are seeing gendered effects, but differently. Similarly, with education, even where in situations where schools have attempted to continue online learning, our surveys in Nairobi in urban settlements found that 1/3 of students couldn't access school lessons even if they were online. But boys are much more likely than girls to use a computer or tablet for school, again, because of differential access to resources at the household level. An existing cohort we have in Bihar and Uttar Pradesh in India, the Udaya study, adolescents there reported 50% of households had no livelihood at all at the beginning of the lockdown in India, which did extend for several months. But on top of that, 29% reported a major reduction in income sources. And this was interestingly higher amongst households with girl respondents. Unpaid care, again, not surprisingly, 1/5 of girls in Bangladesh in a survey that we conducted reported increased workloads in chores, probably due both to more people being home, but also girls being available to contribute to that work due to school closures. And lastly, as already been suggested, there are risks of violence and early marriage, though those data are emerging, and right now it's unclear. But we do know, for example, in Kenya, half of women in the settlement stopped purchasing sanitary napkins. There's very, I think, good documentation, at least in India, on access to family planning services, for example, being curtailed, as well as other maternal and reproductive health services. We've seen reports of violence, and at least close to 20% of girls in Bangladesh reporting increases around them or higher. But I'd like to note here also the difficulty of collecting data on violence given the ethical concerns. A lot of these surveys are done through mobile phones, and the Council has been advocating, for example, using other data sources as well, like implementation research or program documents, to avoid putting girls at risk in answering these questions. That said, the risk is clear and continues to emerge as these data emerge. And the situations continue to change, and we're repeating a lot of this collection in different countries. So I do encourage you to look at the Dataverse site to see emerging findings. So given the fact that we know adolescents are facing risks in a wide variety of ways, we decided to examine, well, what is the potential of organizing girls? We know what's happened with women's groups in many settings. There's limited research. We've already heard about the data from Ebola settings around girls, but one of the things that study also found was that girls who had been part of an empowerment intervention in a girls' group actually were able to mitigate the effects of Ebola also in the long term. So there are potentials around these sort of interventions in, I think, maybe 6 areas or probably more. This is drawing from 2 systematic reviews conducted around adolescent girl programming by Nicole Haberland and Miriam Temin, colleagues of mine at the Council. And we know that, for example, girls groups provide empowering but also protective spaces depending on the setting. These programs tend to be very different context to context, but typically involve a group of 10 to 20 girls meeting regularly, often weekly, undergoing trainings like financial literacy to build economic assets, or even including opening bank accounts, for example, to improve their access to savings. Building cognitive, social, and emotional skills. We've seen life skills training, different types of participatory learning, peer education. A lot of these programs, the vast majority, actually aim to improve sexual and reproductive health outcomes through both information and linkages to services. Many of the groups have an underlying approach to foster rights, both in terms of entitlements and access to services, but also girls understanding their role in the household and in society. And lastly, a lot of programs have seen that these are an opportunity to promote equitable gender norms. I'm not going to go into a review of the evidence right now, but I will say that given the diversity of these types of interventions, so for example, a recent review examined 30 programs, very diverse range of outcomes and also interventions. So it's difficult to synthesize, but I will say thematically, these are the main areas that emerge as areas of promise. And effects vary again by setting, type of program, as well as intensity of the intervention. So what we tried to do was, knowing what we know about girls' groups, well, what happens when COVID, in this situation with social distancing in particular, how will these groups be affected? So we hypothesized pathways through which they may be affected. We know that, for example, these programs really center on the role of the mentor. Girls' groups are mentored, for example, by someone in the community that can help them build a whole set of skills, but also relationships. Now, during the pandemic, there is, of course, the risk of illness and mortality, but smaller, as we know, for adolescents. But really, it's the social distancing, the lockdown, the continued lack of access to schools, the lack of access to these groups that is going to affect them the most, and lack of access to also health services. And we anticipate that this would increase isolation, amplify existing inequalities, but also put increased pressure on girls in particular to earn money, as well as boys for that matter, but maybe with different outcomes in terms of child marriage or entering the workforce without finishing school. We had seen anecdotal evidence of both stress and violence, as we know, and this hypothesized that this will continue given these underlying stresses that are emerging. So our sense from knowing what we know about women's groups is at the community level, girls and mentors could help provide accurate information about COVID and also be a source of support, albeit limited given the fact that a lot of this needed to be done through technology or through smaller spaces. So in order to understand what was really emerging around these areas, colleagues of mine interviewed representatives of 12 programs in 11 countries that are here, which are all different types of girls groups programs in different settings you'll see in both Africa, Asia, and in Guatemala. So what did we find? Well, we found that, as expected, groups were heavily disrupted in terms of they could not meet because of social distancing guidelines. Those who could meet, though, it was really shaped based on who the participants were. So the vulnerability of participants themselves dictated how functional the group could or could not be as time moved on. So for example, in Bangladesh, where girls had access to mobile phones in a certain setting, they were actually able to continue with activities with smaller groups of girls, three girls at a time, for example, but the mentors were able to provide them information that they didn't have around COVID or other services. However, in other areas, like in Benin, we found that groups, because they couldn't meet in a rural setting, decided to do mini groups at the village level. So again, girls weren't completely cut off because mentors were able to adapt or to facilitate different ways of meeting. And I think that's the power that we saw with, despite lockdowns, groups were finding ways to be in touch with their members, either through home visits, phone calls, or if technology was absolutely not available, at least through word of mouth. For example, in Nairobi and urban slums where people were living close to each other, girls were also able to meet. Groups also sprung into action in terms of these, and I think this is consistent with what we've seen in much larger scale programs with women's groups as well, that providing food and support, for example, immediate distribution of food packets, relief services, hand sanitizer, masks, or even in the case of providing seeds for kitchen gardens in Guatemala. And despite the fact we know that education is really dependent on institutions and education policy in a country, or health policy dictating the terms of education, some groups did try to support educational endeavors to the extent they could. And lastly, though less so, groups can be engaged in the community response, and I think this is incredibly important, given that we know engaging communities has been a cornerstone of the effective responses. Groups such as these can be both linkages to services, but also sources, for example, of livelihood support. And I thought in an interesting case in New Delhi, an NGO, YP Foundation, reported that girls themselves started providing relief services in their community and played a different role, and a sort of empowering role in the community, seen as providers of services, not just recipients. Overall, I think what we've learned from these insights is that there's incredible promise. These are small, of course. These are not at scale or through governments in most cases, but they do show the potential of these sort of multi-sectoral programs, which in many ways are more flexible than groups that are already linked through governments or through financial services like banks. Because they're flexible, they have wide reach and trust, most importantly, amongst their members and their mentors. They were able to adapt quite rapidly to meeting both basic needs, but also considering longer term responses around both social, psychosocial support, and also access to services. So the existence of the group itself facilitated reach. And I think that's the crux of what these groups can offer. They also reported a whole set of challenges that were quite common. The loss of meeting spaces meant that girls are, if they're on the phone, for example, speaking in front of family members, potentially about sensitive issues. Also, the loss of meeting spaces means the loss of that sort of social and emotional support, despite all of the attempts that people have made. I think the most striking here is also the access to technology. This is data we looked at from India, Nigeria, and Uganda. And you see that in India, about a quarter of girls in the age of 15 to 19 have access to a mobile phone. So though there's great discussion about online learning or access to technology being a way to mitigate the effects of the pandemic, the reality is inequities in socioeconomic status, rural, urban location, household allocation of resources means that a lot of adolescents, and girls in particular, as you can see, suffer more from lack of access to mobile phones for the most part, though you do see certain differences. This is something to also keep in mind, I think, in the general optimism around technology. The third is that the pressure to generate income amongst adolescents, and this probably affects boys and girls differently, but it's important to remember that this pressure will continue. In India, we've seen the economy contract, for example, quite considerably, and some of that burden is likely to fall on adolescents who will have to contribute to household incomes, likely dropping out of school or perhaps marrying early for girls. And lastly, curtailed health services in general and sexual and reproductive health services in particular are an issue being faced across. We've seen data emerging around unmet need for family planning, particularly amongst young mothers, adolescent girls who are married, and also access to maternity care for younger mothers as well. And this is common, I think, in most settings, and not just limited to these three countries or any of the settings we've worked actually. So I think what emerges out of this, and what I'd like to leave you with, is we've been considering, well, what is a reimagined future? There is a unique role for girls groups such as these, even in the limitations of knowing at present the limited scale. Still, there is a role for community-based interventions, and successful public health interventions globally have learned the importance of mobilizing communities, of engaging communities in different ways. And I think this is one option amongst many in terms of potential ways to reach girls and boys and the adolescents. So what we've seen in terms of adolescent girls till date has been largely around engaging them in their own lives. What is an area of great potential is probably to also use them as a gateway, these groups as a gateway to engage the broader community, but also to engage with government service delivery, something we're seeing more of in certain settings. Secondly, I think the role of community-based mentors has been the absolute cornerstone of these types of responses, similar to facilitators in women's groups, as we know. The fact that these mentors live in the community as girls means that they're aware of local needs, they're able to quickly react, but also to ensure a more equitable response. So for example, in the situation where girls didn't have access to their parents' phones, if there were even meetings on the phone, the mentors were quickly able to adapt and change scheduling, for example, of the meeting. And this is the power of ensuring that these sorts of interventions are community-based at their core. And also in terms of, as we move forward, if technology continues to be a major part of responses, particularly in terms of mitigating the effects of school closures, groups such as these can be a part of ensuring inclusion. It's an easier way in some senses to understand who's left out as opposed to who is included. But again, the role of mentors there is key in trying to reach harder to reach girls and boys for that matter. An area of great, I suppose, promise is this idea of multi-sectoral interventions. And you'll see this a lot in the literature on groups, both with women and with adolescents. With girls is that, well, they exist, so we should do health and education and life skills training and 3 other activities because this is a platform in a sense. And the evidence is really, I would say, mixed or emerging on this front. There is something to say for the fact that these multi-sectoral interventions with girls are likely probably to keep them engaged longer and address different facets of their lives. The challenge is ensuring that each element retains quality. And we've seen different outcomes in different settings with that, just something to keep in mind. And lastly, really, I think this is an opportunity to consider programs like this at scale. In India, for example, we have a national adolescent health program, the RKSK, that includes peer education, and there is room for considering these sort of groups at scale as well. And of course, though I focused on girls groups, there are mixed groups and there are boys groups in particular. And it's an opportunity to consider really strengthening interventions such as these based at the community to organize boys, girls, as well as adults, as we've seen in the case of women's groups that have been very effective in many settings in improving health outcomes as well as accountability. So I'll leave you with that, which I hope is a voice of promise and what it sounds like a very bleak outlook in many cases, what we've been hearing this evening. And in the face of what COVID has brought to us, this is just one component, but I think an important component when we consider community-based interventions, mobilizing communities and engagement, and something to be examined much more as the evidence base grows in this area. And on the note of evidence, I will leave you with our resources on COVID are continuing to grow, and we really encourage you to collaborate, use these data. They're publicly available on Dataverses. You can see they're already widely being used. So both at the Pop Council's website or at the Women's Group's evidence website, you'll find a whole range of data sets, evidence reviews on the effects on adolescents and sexual and reproductive health, on abortion, vis-a-vis COVID, as well as a whole range of resources on gender and COVID. And I will leave you at that, and thank you very much for the opportunity to present our work here.
Sapna, thank you very much for that very comprehensive review on the role of groups and the ways in which they've been disrupted, but continue to provide opportunities for, particularly for girls. I'm glad that you mentioned boys there at the end as well. We're going to move on to our last speaker. And I just want to say once more, please use the Q&A box. If you have questions, now is the time. Don't hold back. Please put them into the box. We'll have limited time at the end to answer them, so our panelists can be answering those questions as we're going along here in these last minutes. Our last speaker, we're very fortunate to have Susan Sawyer with us late at night in Melbourne. She is the Geoff and Helen Handbury Chair of Adolescent Health at the University of Melbourne, the director of the Center for Adolescent Health at the Royal Children's Hospital. She leads she's on the Special Advisory Group for Adolescent Medicine for the IPA. Susan is going to be talking with us about adolescent sexual and reproductive health in the context of COVID-19. Susan, thank you.
Thanks, Gary. And in terms of thinking of the order of this presentation tonight, I felt that my presentation probably would sit better at the end, but I forgot how late at night that would be in Melbourne, so I'm starting to regret that. Anyway, what I'm wanting to do is to take a slightly bigger view of adolescent health in the context of the COVID pandemic, with the recognition that this is probably going to be going on for much longer than I think many of us might have thought right back at the start of the year. Maybe this is me in our second hard lockdown in Melbourne, but I think from everything we're seeing about cases, this is going to be something that's going to be with us for a little while yet. And obviously, in terms of that bigger picture view, if we put into context adolescent sexual and reproductive health, we can recognise how critically important this is to reaching our SDG targets, which were to further reduce maternal and child mortality by 2030, following the good work that had been achieved, particularly in terms of reducing childhood mortality within the Millennium Development Goals. Adolescents, because of the higher rates of maternal mortality and the higher rates of neonatal mortality and poor health outcomes in infants, have been viewed as a target. And this is particularly given that whilst we know that overall in the world, a quarter of all pregnancies are unplanned, that approximately half of all pregnancies in 15 to 19-year-olds are unintended, with very high needs for unmet contraception that I'll be talking about in the next slide, with the repercussions of all of this relating in basically too many unsafe abortions each year. Indeed, it's been estimated that overall there are about 25 million unsafe abortions each year, and adolescent girls constitute a significant proportion of those. And in relation to that, this is in the wider context that adolescents have got poor health literacy, low demand for health services, that comprehensive sexuality education is considered a human right, and that adolescents have emerging needs for sexual and reproductive health services. So while we can recognise that in relationship to essential services and SRH being considered part of essential services, that whether young people themselves recognise that they have needs for these services is highly questionable, certainly in terms of young people's emerging needs for contraception, for example. Just a couple of slides to highlight some of these challenges with young people. In this recent study, this was published just this year in JAMA Open, a very nice study of 130 data from 103 low middle income countries where they used the multiple cluster indicator surveys and DHS surveys to look at the comparison of between adolescents aged 15 to 19 and 20 to 34-year-old women, showing that adolescents were indeed less likely to use modern contraceptives than older women, were more likely to have unmet needs, and that over time, and they basically included surveys where the first lot was in the first decade and the second survey was in the second decade of the millennium. And whilst they had shown that adolescent use of contraception had increased, adult use had increased greater, so that inequalities persisted. And over time, there was growing inequality due to the prevalence of unmet need being unchanged in adolescents in comparison to it reducing in older women. And this was particularly the case in a number of countries, in about 18 to 20 countries, depending on how we look at it. And so in India, for example, we can see that both younger women and older women also had increased unmet need for contraception over time. And these authors suggested rightly that there is a pressing need to develop more age-appropriate strategies for both increasing access, but also for maintaining contraceptive use in sexually active girls. And these data, again, relatively recent data that I think are really pretty appalling data in relationship to what we know of the extent of mistreatment during childbirth. This was both birth observation data and survey analyses of childbirth in 4 different countries. And basically about 1/3 of observed women of women overall had experienced some sort of physical or verbal abuse, stigma or discrimination whilst giving birth. They also described a number of other forms of mistreatment, including lack of consent for vaginal examinations, episiotomies and caesarean section. But that it was young women, 15 to 19-year-olds, who were much more likely to experience these forms of abuse, particularly poorly educated women, those who had no education or those with some primary level education only, and that young unmarried women as well at greatest risk. So that young women are, if you like, at greatest risk of lack of access to services and at greatest risk of being mistreated, of being scolded, of, in a sense, not having a high incentive to return for services either. Now, at the start of the pandemic in March, certainly outside of China, that SRH services were deemed to be essential health services. But during pandemic lockdowns, during travel restrictions, and compounded by consumer fears of accessing health services due to fear of infection, we've certainly seen very significant lack of access to family planning services. So this is data from International Planned Parenthood Federation. They have closed thousands of family planning facilities. In these countries here, they've closed over 100 different facilities having to close. As John, I think, reported earlier, the supply chains are increasingly reported to being affected, not just for contraceptives and condoms, but in the States, for example, just in the last couple of weeks, STI testing basic equipment is being really challenged, and there's lack of access to a number of test kits. And again, it's going to be the youngest, the poorest, and the most marginalised who are at greatest risk in terms of access to services, particularly given that for adolescents, so much of their access to health services is mediated through their parents. What else has changed? Well, perhaps not changed is the wrong word, but there has continued politicisation of sexual and reproductive health. Again, I think it was John who suggested earlier that in the US in particular, in 11 of American states, there have been court cases in relationship to reducing access to abortion. This has similarly been seen in Brazil. There are a number of countries that we are aware of. And obviously, in the States, again, just with this week with Ruth Bader Ginsburg's sad demise, that again, this notion of the politicisation of abortion in particular, and of young women's access to contraception and the fragility of this at the best of times, yet in terms of these COVID times, the risk of undoing the legal access that has been done, as fragile as that is in so many different countries. Now, as we've talked about with our 3 earliest speakers, there are both indirect effects of COVID-19 in terms of threats to young people's health and well-being overall, including their sexual and reproductive health. And Sapna just earlier highlighted the concern of the failure to return to school and the risk that this places young girls out of early marriage in particular, as well as direct effects due to reduced access to health services, interruption of clinic supplies, reduced demand, as I've mentioned just before. But at the same time, we know that there are indirect effects of school closures on adolescent sexual and reproductive health. Russell's spoken very well of those direct effects, but just like in terms of girls' groups, in the same way that there are many indirect benefits of schools in terms of safe spaces to be building connection, identities and dreams for young girls and boys' futures, connection to supportive adults, commitment to continued education, endorsement and linkage through to community programs. And furthermore then is the access that both boys and girls have in many countries in the world, particularly in Latin America, where there is a strong school health service for access to clinical services themselves and referral onwards, but ideally also to comprehensive sexuality education, to menstrual care products that has already been highlighted, and importantly, in terms of SRH, to immunisation for human papillomavirus vaccine. A word on comprehensive sexuality education, and this is again, in the context of a few months of a tight lockdown, we might be less concerned about access to comprehensive sexuality education. Where I am in Victoria, schools have been effectively locked down from early March through to what is anticipated to be at least through to October, one way or another. So in terms of the challenges that adolescent girls and boys are getting to preventative sexuality education, this is a particular challenge now. But this is particularly when it was, if you like, even prior to the end, to the pandemic, highly concerning in terms of the variability in the provision of sexuality education worldwide. And so there's recent data here basically continuing to demonstrate what we know well about very variable standards, many countries not having even basic school curricula and education standards, limited progress, and calls for much greater focus on empowerment within comprehensive sexuality education, moving away from reproductive physiology, emphasis on abstinence only, to much more focus on power relationships, gender norms, human rights, life skills. And I'd really bring your attention to the 2008 UNESCO technical guidance here. Data here just signalling that in terms of girls in particular and access to menstrual education, to health services, to materials, regular pads, we can see here in this study that this is data from 3 different regions in India. The stippled colours, the paler colours, are in what were called model schools, where there were NGOs providing both sexuality education as well as resources. And you can see the quality or the relative access to care and the access to teaching about menstrual hygiene management, the provision of pain relief that was actually available in these schools, as well as greater access to quality disposal facilities. But in many states, very poor access in mainstream schools. So in terms of thinking about the elements, when we build back better our notion of comprehensive sexuality education in schools, this is not just about sexuality education, it's around a whole lot of resources as well, and a linking through to actual health services, which are increasingly recognised as needing to be delivered in schools, as well as the provision of education. In my own state of Victoria, as I mentioned, there's been within the Family Planning Victoria a rapid pivot to the provision of greater education to teachers, greater material provided for parents and carers that has ever been provided before. But in a conversation I had earlier today with teachers within family planning, this was the quote that they had, that despite all of this, they're reckoning that there will be many, many students who will be missing out on all forms of sexuality education, which is not simply important in terms of provision of access to contraception, for example, but is a human right in terms of access to information about bodies, particularly at critical times of puberty. And again, in terms of my own country having school-based immunisation programs for human papillomavirus, in Victoria, there will be no delivery of HPV vaccines in schools this year, with very dramatic reduction in terms of primary care as well. There is, however, some good news in terms of the pandemic providing disruption as well as opportunity. These 2 websites are simply websites that have been put together in Indonesia and Nigeria. neither new in terms of COVID. This one from Indonesia last year, the Nigerian, my question is education as a vaccine that's been running for over 10 years, but providing opportunities for adolescents to be telephoning, texting, emailing and Facebooking in relationship to questions that can be anonymously asked about sexual and reproductive health. And I think the opportunities here for better alignment about online resources, increasingly where young people do have access through the school-based and community resources, I think is an obvious opportunity for us. Clearly, telehealth has been the biggest disruption in terms of the delivery of health service, a huge opportunity. This quote from Steve North in a recent editorial in the Journal of Adolescent Health suggesting that in the States in 2016, only 11.8% of family physicians and pediatricians worked in a practice that used telemedicine, but after 2 months of COVID, only 9% of primary care physicians worked in a practice that didn't offer telemedicine. This has been a hugely rapid change with the need for an equally rapid change in policies that underpin financial reimbursement, licensing and prescribing, equipment security, the ability to prescribe controlled substance, for example. And this is where health professional associations have been doing a very large amount of work working with national governments. For adolescents in particular, there's huge challenges around confidentiality and equity. Telehealth in my own practice, far better than not being able to see young people at all. But I must say I've provided, I believe, the poorest quality of care in terms of detailed psychosocial assessments that I've provided in the last 25 years. And this is where, again, further disruption and opportunities required to be thinking about how do we actually have pre-consultation assessments in order that we don't have to be asking questions to young people in their homes where we know the answers may be very unsafe. There are opportunities, however, that telehealth brings us to provide healthcare directly to young people in vulnerable settings, such as youth justice, for example, where there is difficulty in terms of employing doctors and healthcare staff to work in these services. So again, this is the future for how we might build back better. I just really want to highlight the top right in terms of the more efficient licensing will be required for telehealth to really leverage the opportunities that it provides to provide medical expertise, not just outside of states and provinces, but particularly outside of countries as well, in a way that currently is really just not available. Outside of a few opportunities, I really wanted to share a particular opportunity of women on the web providing mailed self-managed abortion, where mifepristone and misoprostol for medical abortion is able to be provided to women in multiple different countries, including to the US. I would bring attention to my colleagues in those 11 states. And since COVID, WHO has also been endorsing self-managed medical abortion up to 12 weeks without the need for pre-engagement with healthcare professionals. Again, hopefully overcoming many of the huge barriers we have in terms of accessing care in many parts of the world where healthcare professionals are just simply not available to be providing abortion care. Finally, I just want to acknowledge the work that many of my colleagues from multiple health professional organisations have put into a joint policy statement that Family Planning 2020 and the International Association of Adolescent Health put together, which, while it was addressing the immediate steps required to protect adolescents' health, was really highlighting that we need to be sustaining and expanding efforts as the pandemic evolves, engaging parents and community stakeholders, as Sapna was alluding to, about how we best continue to support adolescent sexual and reproductive health as the pandemic continues to evolve. In the middle, I would like to draw your attention, and this is my last slide, to some new school health services guidelines that WHO will soon be releasing. And also next year, there will be new global standards for health promoting schools. In both of these, we need to be recognising the role that young people have themselves in contributing to the quality of care. And I'd like to then, if you like, bracket young people's contribution again with the opportunities from health professional associations, as well as obviously in the sexual and reproductive space, the huge amount of work that our various NGOs do, International Planned Parenthood and other key organisations. Thank you very much.
Susan, thank you very much for that very comprehensive overview of sexual reproductive health. I really appreciated your mix of highlighting concerns, areas where we're really seeing massive impacts of COVID-19 on sexual reproductive health for adolescents. But you balance that also with a sense of new opportunities, and I think that that's a very fitting way to end out our time here in this seminar. That it's really such a mix that we're all facing. We're all feeling the tremendous impacts of COVID. The looming indirect effects that are coming, which each of our panelists highlighted in various ways. But on the other hand, the opportunities to think about working in different ways and achieving impact through different means. And we heard elements of this spread throughout the different presentations. We are over time, so I'm going to go ahead and close out the session. We've been monitoring the Q&A, and we've had responses, I think, to all of the questions, but perhaps one. There was one that came from Marcia Zarilla, who was asking about young people's voices and the importance of hearing young people during this period of time, listening to their voices, helping to amplify their voices, and wondering ways in which we can do that better. I will leave that question open. Marcia, I would invite you to, if you're still here, to send us your email, and we will ask our panelists to respond to that. I want to thank you all for joining us for this session. We have 26 attendees here to the very end. Thank you so much. Thank you for our panelists from around the world at various times and joining us for these fantastic overviews of ways in which COVID is impacting adolescent health, ways in which it's differentially affecting across gender, across boys and girls. We heard more about girls than we did about boys, and I would just highlight that as a need in this space is to be thinking broadly about the impacts across the gender spectrum. The next event for the coalition is being contemplated for October, a session on nutrition. We hope to see you all then. Please take care, be safe, be well, and again, thank you all for joining us. Bye-bye.
Thank you, Gary.
Thanks, John.